Donc la dernière session, ça va être un peu sur comment on peut se projeter dans l'avenir. On a vu le système des AAV, les défis actuels, comment on peut s'organiser, ne serait-ce que pour le début des soins en thérapie génique. Et la question que nous avons posée à Stephen Pipe, c'est comment on peut améliorer aussi bien l'efficacité que les effets secondaires de cette approche thérapeutique. Hi Stephen, can you hear me?
Bonjour.
Do you prefer in English or in French?
Oh, definitely English.
Okay. Thank you very much for joining us. We had very hot discussions since this morning, and I'm very happy to welcome you in this discussion.
Yeah, I'm happy to be here.
And we would be happy to hear your point of view, how we can improve the safety and the efficacy of hemophilia gene therapy that we currently have in our hands.
Yeah, no, I think this is a great topic. Looking over your presentations from earlier today, I think we can now have a conversation about what I sort of foresee as some of the follow-on clinical trial strategies that might improve on safety and efficacy for hemophilia gene therapy. So I'd like to start to focus on clinical considerations, because these are things that I think we can pay attention to, even with the current generation of clinical trials that we are engaged in, as well as eventually having commercial access to these therapies, as we now do in the US. So you can't have a discussion about safety and efficacy of gene therapy without a firm focus on the liver. The liver is the target organ for AAV-based hemophilia gene therapy clinical trials. And there's good reasons why we have selected the liver as the target for these strategies. It is the main site that is capable of both factor VIII and factor IX synthesis. A mature liver is attractive because of the slow turnover of the mature hepatocytes. And there's easy access of the vector particles to the hepatocytes following systemic administration. So even though in the early trials, they did strategies such as catheter-directed administration, even with a regular IV infusion, there is selective targeting to the liver through that delivery method. And we can also target the liver for expression by using liver-specific promoters and by using AAV serotypes that have specific tropism or targeting for the liver itself. Liver-directed gene therapy clinical trials go well beyond what is being used in hemophilia. About 21% of the AAV gene therapy clinical trials target blood disorders. Now, these are mainly Hem A and Hem B. But these vectors have proven to be at least the safest and most effective vectors for the current generation of gene therapy as we are doing it currently. The capsids for the recombinant AAV vectors demonstrate sufficient organ tropism, and what we've been doing over the years is trying to identify what's the optimal transduction that we can achieve with these vectors, and how can we minimize immunogenicity. So what have we learned about safety data from the clinical trials to date using this strategy? There's no question the biggest hurdle of AAV gene therapy has been the immune responses against the capsid proteins, the genome, and potentially the transgene product, especially when this vector is being administered systemically. These immune responses sometimes preclude patients being able to participate in trials. At least under current vision, They definitely preclude redosing of the therapy. So should a patient fail to have a sufficient response, we don't have a clear visibility of how we can redose those patients. And then we have the short-term liver toxicity associated with delivery of current generation AAV vectors. And this manifests as the transaminitis. In the clinical trials, this has predominantly been an ALT increase rather than an AST increase. Most investigators believe this is a sign of liver inflammation. But it's important to note that this transaminitis is both asymptomatic and transient. So from a clinical perspective, this has not introduced any liver dysfunction in any of the clinical trials, at least within hemophilia. Some of the things that are believed to be important related to this risk are the choice of the AAV construct, and this could be both the capsid choice, but also the type of promoter that's being used, and then the dose that's being delivered. But we have to be careful when we're trying to compare between clinical trials and between vectors when we're solely looking at the dose, because the dose that's used is also going to be influenced by the efficiency and tropism of the vector for the liver. So I don't think we should always equate higher dose regimens with a vector that has relatively low tropism as being having a higher risk than a AAV vector that uses a lower dose but has a much higher tropism for the liver. The other important aspect about this is the liver health of the patient, both before and after gene therapy. Now, there are potential safety issues for all the gene therapies that are in development for hemophilia. Some have been realized, some are only potential or theoretical. So we've already mentioned the liver toxicity, the immunity. This is not immunity as it relates to response to the vector, but impaired immunity in the subject or the patient because of the immunosuppressive therapy that's often required with these protocols. There can be consequences of markedly elevated factor expression, and thrombosis has now been observed in some of the clinical trials. And oncogenesis probably is a concern in theoretical form only at this point. It is, although several tumors have been observed in the clinical trials to date, these have been closely examined, and I'll refer you to one case that we were involved in the Tranidez trial. But it seems that the oncogenesis that has been observed in the trials to date has more been related to the patients who've participated and their underlying risks rather than the therapy itself. But it remains an ongoing concern for investigators and clinicians and patients alike related to some of the integration events which are known to occur with AAV. So let's talk about the risks associated with immunosuppression. Corticosteroids have been the primary therapeutic used to manage the transaminitis in the patients who were participating in the trials. But other immunosuppressants have been used. Some patients can't tolerate corticosteroids. Sometimes they haven't responded to the corticosteroid course, and so alternative immunosuppressants have been used. And depending on the characteristics of the immunosuppression, they come with a whole host of additional potential adverse events. The immunosuppressive protocol is part of every clinical trial protocol, and as well in the clinical delivery post-marketing. The majority of the adverse events in the clinical trials have actually been related to the immunomodulation rather than to the administration of the drug itself. And so there is some thought about new strategies around immunosuppression. For instance, does prophylactic versus a reactive use of corticosteroids potentially reduce the total dose that is needed to manage the immune response? Is it possible it will reduce the window of immunosuppressive effects? We don't have clinical trial data yet with some of these interventions to guide us, but these are things that are being looked at in ongoing clinical trials. The immunosuppressive effects in the patient can be a real concern. Infection risk, tissue inflammation, and potentially even malignancy risk if a patient is on prolonged immunosuppression. The specific drug side effects, for instance, with corticosteroids, are well known, and these have been observed in all the clinical trials to date: weight gain, hyperglycemia, hypertension, flares of acne, sleep disturbance, headache, irritability, GI distress, etc. And so there is a real desire to be able to minimize both the need for introducing immunosuppression and the dose and the duration of these interventions. What can we envision? Well, in some cases, with the current therapies that we have available, improved adjudication of the triggers for the corticosteroid course can make a difference for the patients. So, for instance, in the HOPE-B trial of etranacogene in Hem B patients, if you look within the adverse events for that trial report, you will see that about 11 patients reported 12 adverse events of transaminitis or ALT and AST elevation. But only 9 of those actually triggered the immunosuppressive course. And that was related to adjudication of the potential causes for the liver abnormalities, and in some cases, alternative causes for the transaminitis was observed. I have seen personal experience with the patients that have participated in that trial. For instance, aggressive exercise or physical labor has triggered transaminase elevations. There's been clear observations that certain concomitant drugs or medications have also been responsible for the transaminase elevations, and even alcohol use can be a potential cause. And so one of the things we can do right now to potentially minimize the immunosuppressive complications is to do a judicious adjudication of what may be going on in the patient, and not just an immediate response to the transaminase elevation to start the immunosuppressive course. There's also a push to reduce the total duration of exposure. So what I was trying to explain is that there's been a real push to try to reduce the duration of exposure. And so I think a focus on resolution of the transaminitis is the main focus of the strategy. And following a plan for a weaning course of immunosuppression is appropriate for most patients. And we've also determined from the clinical trials that, the main window of concern here is probably between about week 4 to week 20. And very late transaminase elevations probably are due to alternative causes, not immunologic related, and therefore a prolonged exposure to corticosteroids probably is not needed in that context. And in some of the clinical trials, we've really pushed not to continue corticosteroids, certainly beyond the first year of therapy. As far as non-corticosteroid approaches, there's a big desire to avoid corticosteroids if possible because of the adverse side effects. Some of the clinical trials have had some experience with mycophenolate mofetil, or MMF as we call it. And there is some good suggestion that that could be an alternative approach. And at least one clinical trial is exploring the use of anti-IL-6 as a target, primarily in a prophylactic setting for the immune response. There's some support for this from an old clinical trial. So if you remember the BAX 335 trial, the patients had pretty significant immune responses to the vector, and most of the patients lost their expression because of the immune response. But there was one patient who has had sustained factor IX expression in that trial. And interestingly, when they did the evaluation of this patient, they determined that, do I have control here? Yeah, it was determined that he was actually haploinsufficient for the IL-6 receptor. So I think there's some rationale here to be thinking about alternative targets, potential other interleukin targets for immunosuppression that might still be able to help us manage or prevent the transaminitis without introducing all of the side effects associated with corticosteroid use. Liver damage can also increase the risk of the liver-related comorbidities in this context. Liver diseases increase the risk for hepatocellular carcinoma development. We know that 80% of all HCC cases are associated with chronic hepatitis B and C infections. And importantly, cured or controlled hepatitis, although it reduces the risk, it does not completely eliminate the risk of developing important liver-related adverse events. So if you look at the clinical trials, some of the clinical trials have enrolled substantial proportions of patients with histories of hepatitis B and C as well as HIV. And in some cases, some of these patients had had hepatitis C for over 25 or 30 years before they had eradication through antiviral therapy. Now, there's good data to indicate that although it's great to eradicate hepatitis C, when you've had such long-standing hepatitis C preceding that, your risk of developing hepatocellular carcinoma does not go to zero just because you've eradicated HCC. So as long as we're going to enroll these patients in these trials, we have to be prepared that we are going to see hepatocellular carcinoma in a proportion of patients, not because of the drug intervention, but because of the population of patients that are being evaluated. In addition, the risk for HCC is about 7-fold higher in patients with HIV compared to those without HIV. And then we can also link high alcohol consumption and obesity as being linked to hepatocellular carcinoma development. So I think if we have concerns about the oncologic risk related to these interventions, we have to be thinking about our patient population on the whole, and maybe that we can consider prioritizing patients who do not carry some of these risks, particularly if this is an open concern for us and the patient population. Now, I mentioned the one patient in the HOPE-B trial with tranidez who did develop hepatocellular carcinoma. This has now been published in Blood Advances just this past month. This individual was 69 years old. He had moderately severe hemophilia B, but he had long-standing hepatitis B and C. His hepatitis C was eradicated to secure entry into the trial, and at least by measures of liver health, he did meet the criteria for not having excessive fibrosis and no evidence of cirrhosis, so he was eligible to participate in the trial. This patient also had a family history of malignancies. That patient had a detailed molecular analysis of both the tumor tissue and the adjacent unaffected tissue that was transduced by the vector. And I think a very careful analysis has concluded that the hepatocellular case was unlikely related to treatment. And if we look at some of the other cancers, as I mentioned in the other trials, consistently, the molecular analysis has not demonstrated any evidence that the integrated elements were drivers of those malignancies. So again, thinking about the population of patients who are potentially going to receive this current versions of gene therapy, these are all these are adult men, in some cases aging men, including those with other risk factors, and we should expect additional malignancies to be observed in the clinical trials. Obviously, there will be detailed molecular analysis over and over again until we are satisfied that there are no drivers from the AAV itself. And ultimately, what we will be left with is an epidemiologic assessment compared to populations who've not received gene therapy. So I don't think the cancer risk related to AAV will be answered in short order. I think it will take a very long time to be reassured that AAV is not a driver of malignancy. Liver disease may also impact transgene expression in gene therapy, and this was conceived even in the very earliest days of AAV targeting to the liver. And the thought being that, well, if you have liver disease and you get damage or anything that would destroy individual liver cells, the impaired liver function was also going to affect transgene expression and concern for loss of transgene expression over time. Does the transaminase elevations trigger destruction of liver cells? I think this is actually an open question. We don't have many acute biopsies that are taken at the time of the transaminase elevations. The biopsies that have been reported to date have been fairly late, like years after receiving the AAV vector. What I can tell you from those analyses so far is that even in the patients who had a history of transaminase elevation, they still seem to have good transduction of their cells. There's evidence of the transgene being present, several years afterwards. So at least in that crude analysis, there doesn't appear that there's a substantial loss of liver cells related to a history of transaminitis. But I think we still need to see some more biopsies that are drawn in the acute phase to understand better what's going on. If we look about what our goals are in the clinical management of patients, both in the clinical trials and now in the commercial setting, we're really trying to protect two things. We're trying to protect the liver, and we're trying to protect the transgene. So, the gene therapy does result in at least a transient strain on the liver. And accordingly, we've tried to minimize other things that could impact the health of the liver concomitantly with their gene therapy. So the clinical things that we can be focused on in helping patients navigate their gene therapy course are lifestyle factors. We still advocate with our patients for alcohol abstinence long after receiving the gene therapy. We're paying attention to weight management and diet. Definitely restrictions on known hepatotoxic medications, but also a careful assessment of any concomitant meds to make sure that these couldn't be potentially liver toxic in conjunction with the gene therapy. And then we've made regular follow-up assessments a key part of the follow-up so that we can continue to reinforce these lifestyle factors long after they've received the therapy. And the only, analogy I could put forward is patients who receive liver transplants. The same types of lifestyle factor and follow-up have been employed to ensure that patients have good, stable outcome after receiving a liver transplant. But we're also trying to protect the transgene. because maintenance of liver health should help to ensure the transgene remains, correctly expressed, and that the protein remains properly folded and secreted, etc. And we also have to manage the immune responses in order to mitigate drug-induced liver reaction and potential loss of transduced hepatocytes. So whether that happens or not, that is still the theory about why we still are using these immunosuppressive courses. So with all of this focus on the liver, the other clinical piece that I think is going to be increasingly important for us to be thinking about is from a clinical trial center preparedness, or a center that's prepared to deliver clinical gene therapy. Is there a role for the hepatologist in the multidisciplinary team? And I can see multiple points in clinical management which can help us identify the right patients for participation, ensure that they receive this safely, get proper management post-infusion, and then also have proper assessments over the long term. So from early on, I think our hepatologists can help us around liver health education of our patients and our staff, proper assessment of their degree of fibrosis, cirrhosis, and hepatocellular risk, and also what are the appropriate lifestyle changes that patient needs to be focused on. From a pre-infusion screening, I think interpretation of liver health assessments is important, and adjudication of those individuals who are at higher risk. What's not seen in the clinical trials is all the patients that were, if you like, borderline in their assessments during the screening phase, who were then ultimately excluded and didn't participate in the trials. Those are in the papers, and you can see that. But we screened far more patients for these phase 3 trials than were actually eligible to receive the drug. And I think that's still going to be the case in the clinical delivery. On the day of infusion, we need to reemphasize the lifestyle changes. But I think the other thing that's important for coordination with the hepatologist, liver biopsy, I think, can be so informative to tell us what's going on in the patient, particularly with some of the events that might happen. And so it's too late to be preparing for a liver biopsy with a hemophilia patient with your liver team in the acuity of the event. And so one of the points of coordination with our hepatologist, we can set up a potential liver biopsy plan well in advance of receiving the gene therapy vector, so that everything is ready to go. So that if a patient chooses to volunteer for a liver biopsy post-infusion, all of the details, the factor replacement that may be needed around the time, and all of the planning for that biopsy is all done in advance, so you can get it done acutely. And then over the long-term monitoring, continued interpretation of liver health assessments, continued guidance to the patient on their hepatocellular carcinoma risk, and then also any coordination of molecular studies from a liver biopsy. I think our hepatologists can also help inform us. So now, those are the things I think we can be doing now with the current generations of gene therapy. Well, what are some of the transgene elements that we also need to be concerned about? So certainly loss of transgene expression is one of the bigger risks for a patient who participates in gene therapy. And the reason is not because of the disappointing outcome for the patient, but further that they may not be eligible for any additional gene therapy due to the AAV neutralizing antibodies. And so a patient who participates now is basically saying, I have one shot to receive this type of therapy. And so if it doesn't work, gene therapy is probably not going to be in my future, even if we develop better second or third generation versions of gene therapy down the line. There's a second consideration, which I think is manageable, but I think is important to realize with our patients. When they come off their factor replacement therapy, they are losing all of their peak corrections, which may be important for their day-to-day management related to bleeding risk. And so if you have a patient who has persistent expression at 10 to 15%, which is sort of typical for the trials after they're well beyond a year out from a trial, then we're really seeing sort of just steady state correction without those peaks, and potentially putting the patient at risk for breakthrough bleeding related to trauma or certain activities. We've mentioned behavioral changes that we're trying to introduce into a patient, the lifestyle factors. But we've observed behavioral changes in the patients after receiving gene therapy that I think also potentially puts them at risk for some adverse outcomes. Their improved factor expression sometimes emboldens them to be engaged in activities that are potentially riskier and has actually triggered some adverse events in even the clinical trial participants. We still have concerns about the altered correlations between factor and outcomes. Even in the patients I've followed, I'm still not certain that the factor level that they maintain after gene therapy is the same correlates as if that patient was on factor replacement therapy or if that was their residual factor level. And so you can see where the uncertainty comes in the patients who are at the borderlines. So the patients who's at the cusps of mild hemophilia to non-hemophilia, there's concerns there about whether the patient's fully protected or not. Can they go through surgeries without any additional therapy? But then on the other end, you've seen in the clinical trials where patients are in maybe the moderate range between 3 to 5%. And it's very variable about whether those patients end up returning to prophylaxis. So there's an uncertainty there about is that factor level still providing proper protection, or do they need to go back on prophylaxis? On the complete opposite end are the challenges of supraphysiologic levels. And at least in one trial, these levels were so high that there were thrombotic events, and many of the patients have had to have been placed on anticoagulation. It seems like this is a transient phenomenon, at least for factor VIII, and I think it can be manageable, but we're going to have to wait for that clinical trial data to show us the path forward for those patients who get really supraphysiologic levels. Still an open question, what is causing the decline of factor VIII expression across the factor VIII clinical trials? Is it loss of non-replicating episomes? I would say my assessment of the biopsy data that has been done so far, there's not much evidence that that's what's contributing to that. We've mentioned destruction of hepatocytes, maybe as part of the immune response. Again, theoretical. There could be other as yet uncharacterized mechanisms that we don't understand about AAV transduction. Intracellular stress, due to the challenges of expressing factor VIII in a non-native cell like a hepatocyte, as opposed to, for instance, liver sinusoidal endothelial cells. Yes, that could be contributing in some way. And then I would point you to a couple of articles that have suggested, I think, quite firmly that transcriptional silencing and epigenetic regulation is actually at the root of the loss of factor VIII expression over time, meaning that the transgenes are still there several years out after dosing, but for some reason the cell has actually shut down expression. The hope there is that with epigenetic modulators, you may actually be able to rescue those silenced transgenes, and that's going to be ongoing investigation going forward. What about alternative transgenes? What are some things that we can do to the transgenes that may improve their expression efficiency? So as you know, the constraints of the size of the AAV vector are such that we have only been able to use B-domain deleted factor VIII constructs. I would say this is not the optimal form of factor VIII to be trying to express at a cell. We know enough about protein folding and transit through the secretion pathway of factor VIII that some elements that are important are potentially missing in these constructs. There are some strategies to try and not increase the size of the transgene, but modify the vectors such that they would improve their transit through the secretion pathway, perhaps improve folding. Some examples here are introduction of new N-link glycosylations within a small B-domain linker. This is a so-called V3 variant of factor VIII, and at least in preclinical studies, this shown strong evidence that it could be superior to B domain deleted factor VIII. And there was at least one clinical trial that was utilizing this version. Some ex vivo strategies modifying the factor VIII constructs by inserting more extended linkers with multiple end-link glycosylations have also shown improved expression, lending credence to this strategy. There are some other strategies, though, of so-called second-generation factor VIII transgenes. And these are derived from comparing to non-human factor VIII orthologs. And insights on canine factor VIII have identified that you can delete the furin site within factor VIII, and you can improve the expression efficiency. Analysis of porcine factor VIII has led to porcine human hybrid variants of human factor VIII. And this particular variant here, ET3, is now being explored in 2 clinical trials, one in a lentiviral trial with ex vivo transduction and then a bone marrow transplant. But there's also a traditional AAV delivery study from ASC Therapeutics that's going to be using this ET3 variant as the form of factor VIII that's delivered to patients. And the ET3 in general has shown up to a 100-fold more efficient, improved expression compared to B-domain deleted factor VIII. And there are other comparisons to other ancestral primates, which have also given some insights to amino acid substitutions that may improve the efficiency of factor VIII expression. What are some other strategies? Well, there's no question that for factor IX, it was the Padua variant that really made a pathway to make factor IX and Hem B gene therapy a reality. Boosting the activity of that protein by up to 10-fold is what has allowed us to do gene therapy successfully in hemophilia B. Is there equivalent of a Padua factor VIII? Well, I would say partially. There are some strategies to introduce, for instance, mutations to have an APC resistant or an inactivation resistant factor VIII. This can be done without increasing the size of the transgene. There are other factor VIII muteins which can slow A2 subunit dissociation. And when 8A gets activated and you have the free A2 subunit, by reducing the speed with which the A2 dissociates from the 8A, you increase the global coagulation potential. So at least analogous to a factor IX Padua, if you like. And there are other modulations which can also affect how either how factor VIII interacts with binding partners like factor X, and then also they can also stabilize the A2 subunit within 8A. So these types of transgenes can be examined as alternative transgenes, maybe in second-generation protocols. The other thing we can at least envision is a so-called bioengineered bypassing strategy. So if factor VIII is just simply too difficult to express safely in the cell, can we express other versions which can boost thrombin generation and avoid some of the complications associated with trying to express factor VIII? So there is a catalytic domain modified factor 7A. And in preclinical studies, this allowed for a 100-fold lower vector dose compared to unmodified 7A in an AAV liver-directed gene therapy strategy. There is something called super factor 5A. This has been engineered to resist inactivation, also by limiting A2 domain dissociation and APC proteolysis. Factor 5A based gene therapy is actually an ongoing area of clinical development, and there will be a clinical trial soon with this strategy. And then we have Zymogen-like factor 10A. These have been engineered to evade antithrombin inhibition by maintaining the Zymogen-like conformation until it binds to its cofactor, factor 5A. So all of these could be envisioned as second-generation transgenes They wouldn't be having the complications associated with factor VIII expression. And they also open up the possibility of treating inhibitor patients. So the last thing that I think we can envision are alternative strategies to the current generation of AAV. And both direct delivery-based in vivo editing or cell culture-based ex vivo editing are being explored in next-generation protocols. And let me just show you an example of each that we're going to be involved in at our center. So the first is a CRISPR-Cas9-mediated gene insertion in hemophilia B, where factor IX is going to be targeted to the albumin locus, using CRISPR-Cas9 gene editing. And the nice thing about this is these transgenes are promoterless. So it at least theoretically reduces the risk associated with transgene insertion off target because there's no promoter elements related to the transgene. Where this gets gene edited, it follows the albumin promoter, and so it's only going to be expressed when it's in the proper place within the genome. This trial is being conducted by Regeneron and Intellia, and we're just getting ready to initiate that trial at our center. The other example are so-called engineered B-cell medicines. So here you can do precise genome engineering of apheresed peripheral blood B cells, and then you do ex vivo gene editing into a safe harbor locus. And in one strategy, they're targeting the CCR5 locus. And then you differentiate these B cells into plasma cells. And the beauty of this is plasma cells are manufacturing machines. They're capable of producing 10,000 molecules per cell per second. These can be then infused back into the patient. And because they're autologous cells, there's no immunosuppression required. Plasma cells are known to be terminally differentiated, and they have an incredibly long half-life of about 17 years. And there's the potential that you could actually repeat dosing. So you could give one dose to a patient through an infusion, wait to see what your expression is, and if needed, you could do an incremental expression. Incremental expression to boost their expression further. If you lost expression after many years, you could come back with a repeat infusion because there's no immune reaction to these cells. There's no bone marrow conditioning needed, and it's been observed that these plasma cells can home and engraft into the bone marrow, the liver, and the spleen. That's what the little graphic is showing you there on the right. So this has been conceived into a clinical trial program now. Some of the challenges of moving this forward can you properly culture, engineer, and then differentiate these B cells ex vivo in order to give back to a patient. And some recent publications have used a modified CRISPR-Cas9 system using ribonucleoproteins and then using an AAV vector to deliver the repair template. But they've shown in this preclinical study that you can take these apheresed B cells, you can isolate them, you can gene edit them ex vivo, and demonstrate that the cells are producing substantial amounts of factor VIII. And so then the next step will be in a clinical protocol to be able to give this back to a patient. So I'm excited about this protocol particularly because of anything that I've seen related to gene therapy to date. This is the only one so far that I can envision for a pediatric patient that myself as a pediatrician could probably get behind. It's incremental. It's not dependent on the age of the liver. And thirdly, the fact that you could redose patients many years later, no immunosuppression required, no bone marrow transplant. I think this gets me really excited about maybe before I retire, there will be a protocol that I could help deliver to pediatric patients to perhaps change their life for good. So thanks for the opportunity to share this with you, and I'd be delighted to hear some questions.
Thank you very much, Stephen, for sharing with us this very, very positive perspectives and how about we can...
Yasim, I can't yet hear you through
Can you hear me? Can you hear me now?
I can hear you now. Thank you.
Okay, sorry. Thank you very much. And thank you for sharing with us all these new perspectives, which give us that we can expect in near future, I hope, how could be the second and third generation gene therapy for our patients. Is there any questions from the audience right now? From the chat? Yep.
So there's a question online. What would be your recommendation be in terms of frequency and biopsy in timeline, pre and post administration regarding the liver biopsy?
Yeah, I mean, I think we're still solidly at a research phase here in evaluating these biopsies. And within the ongoing clinical trials, a voluntary liver biopsy consent is obtained for most patients. What I said we're missing is we don't have a longitudinal biopsy. So we don't have a biopsy of a patient like year one and then a follow-up biopsy, say 4 or 5 years later. So I think that's what I'd like to see so we can compare that data. That will help answer questions about, are we losing transgenes over time or not? But secondly, we have to get some biopsies in the acute phase when a patient has active transaminitis, during immunosuppressive therapy, and at resolution, so we can properly characterize what's actually going on at the cellular level and at the organ level. So I don't think this has to be done in every patient, certainly, but hopefully some of our patients who participate will volunteer for this and really help advance our understanding going forward.
Thank you. Maybe one question on gene editing. The major limitations of the current gene therapy are mostly related to AAVs. And I mean, in terms of eligibility of the patients, this is a one-shot treatment, and also liver toxicity. And when I look at the approach of gene editing, there is, again, AAV vectors in it. Can we expect that the amount of AAV that will be administered will be less than the current gene therapy? And can we hope that the liver toxicity will be less? Or can we use liposomes or other strategies as deliver strategies?
Yeah. So the Regeneron in vivo gene editing I show you does use an AAV to deliver the guide RNA. It does involve a lipid nanoparticle infusion of the CRISPR-Cas9 components. So the way the clinical trial will go, the patient will get AAV infusion first, and about an hour later will then receive the lipid nanoparticles. The nice thing about those two components is nothing will happen related to receiving the AAV at all. The only way any editing will happen is the patient will concomitantly receive the CRISPR-Cas9 components. So you don't have to provide a very high dose of AAV in order to deliver enough guide RNA to get efficient editing. So I think it remains to be seen. I mean, no patient has been dosed with this protocol, but the guidance from the preclinical studies would suggest we could use much lower doses of AAV. I don't think it will help us get around eligibility, because if you have, the Regeneron trial is going to use an AAV8 vector. And so if you have pre-existing immunity, you will not be able to participate. And then almost certainly the neutralizing antibodies post-infusion will be so high, you won't be able to be redosed. So this is still an eligibility and a redosing challenge.
Okay, thank you very much. There is a question from the audience.
Hello, my name is Thomas Agnier from the French Hemophilia Association. Thank you. I will try to ask the question in English. So you underline not using, it's a very practical question, so sorry for that. You underline not using of hepatotoxic medication during the gene therapy. However, a lot of patients, especially those who are more than 30 years old, take medication against pain, which are most of the time hepatotoxic. So how do you manage this in your center? And what kind of advice can you give us for dealing with it? Thank you.
Yeah, I think this comes under the category, patients can be technically eligible for participation in a trial or eligible to receive gene therapy, but they may not be suitable. And so I think part of the assessment of suitability is, do other pathologies the patient may carry just make them not a suitable recipient for gene therapy? And I think a patient who is having to rely on a lot of potentially hepatotoxic medications for whatever reason, including, managing chronic pain, if they can't contain and use alternative ones, I'm not sure that they're a good potential suitable recipient for gene therapy. We saw this also, like for instance, in the Roctavian trials, although we dosed our first couple of patients that also included concomitant HIV, subsequently they were not eligible for future participation in the trial. And part of that was because some of the anti-HIV medications were being used were linked with a significant transaminitis. So there are certain drugs like efavirenz, which absolutely you cannot use concomitantly with factor VIII gene therapy. You may be aware also of a patient who received isotretinoin, so Accutane, was taking it for acne, and the Accutane completely silenced their factor VIII expression. And they withdrew the Accutane, and the patient's factor VIII response came back partially. So we clearly have to pay attention to concomitant meds, and patients who can't change or avoid using these meds, then I just don't think they're suitable for being a recipient.
I have I'm allowed to have a follow-up with you, Steve. So thank you so much.
Sure.
It may be the first time that such a strong recommendation was given. I mean, in what I know about the question of gene therapy and patient management, pain management. So it's a very strong one. That means that a patient who are hemophiliac with a lot of arthropathy and cannot deal with or have difficulties to pain management and hope that gene therapy could be a solution. Actually,
yeah,
what you said, it means not really.
Yeah, I have reservations about whether these patients are really suitable. One thing I think you could at least evaluate in the patient is if they respond well to gene therapy, will this in any way allow them to reduce their pain medication use? If it's end stage arthropathy, I'm not sure. I have some guys that have participated in the trials who had pretty substantial arthropathy. Their pain did improve considerably after receiving gene therapy, and some of them are no longer using any pain medications for chronic use. So I do think that's possible. I just think it requires a clear evaluation of the suitability of that patient, and I don't think we should be making promises to them, about what their response can be.
Do you have any recommendation, any score, or
No, I think it's more related to evaluating how much drugs they are using, whether they are potentially hepatotoxic, and is there an appropriate substitute that the patient could use, at least during the risky period. So remember that window between like week 4 and week 20. That's where I really want to minimize any exposure to concomitant meds that could, fool us into thinking that this is an immune reaction from the vector when really it's being caused by other mechanisms. That's what happened with the patient who was on efavirenz for their HIV. They had a substantial increase in their ALT, and everyone thought that it was an immune response, they stopped the efavirenz and everything resolved. So I think if there's at least a window of time where you could minimize use of those drugs, use alternative methods that are not potentially hepatotoxic, then maybe the patient could still get this treatment.
Maybe another question on your real-life experience with gene therapy. Génique and Roctavian, they are both available in the US, and I was wondering how many patients have been dosed in the US since they are on the market, not from the studies.
Yeah, so only 3.
Okay.
And only one patient has received Roctavian, and that patient was not in the U.S. So, what's the holdup, you say? It's firmly at the level of the payers and the contracts, the individual contracts for patients. I think if you followed the challenges in Germany in moving from regulatory approval to actually patients receiving therapy, they are having the same issues, and we're seeing it. It will happen. Even at my center, we now have a contract for purchasing the drug from the company. We're working out the details now of how to support my clinical staff to compensate them for the extra workload that's required to deliver gene therapy. So I think if we figure out that last hurdle, I think we'll be ready to go. The challenge for me as an investigator, though, is there's still so many clinical trials to offer. Most patients don't have to receive commercial gene therapy. There's an open protocol waiting for them that they can participate. So in general, I've not really been pushing at the payer level to get approvals when a patient is willing to participate on a trial.
Okay, thank you very much, Steve, for sharing your experience. Thank you for your time. And I think there is no more question. So, hope to see you in person next time. And thanks for your time.
Yeah, thank you again for the invitation. I hope you had a great meeting. Bye-bye.
Bye-bye.